To introduce you, so Paul Vester is a National Health and Safety Specialist with the Canadian Union of Public Employees, providing knowledge and support to CUPE members in Ontario from the workplace sectors of healthcare, social services, municipal, school boards, and post-secondary. Paul is a board member of the Workers' Health and Safety Centre, a member on the Section 21 Healthcare Committee, and the Provincial Working Group on Health and Safety for the education sector. Prior to working for CUPE, Paul worked for 25 years as an education worker with the Conseil Scolaire Catholique Providence and was an active member of CUPE Local 4299. He currently works out of CUPE's regional office in Markham, Ontario, but still calls Windsor home. It's quite a commute. His passion lies in consensus building among stakeholders towards better health and safety conditions for everyone in the workplace. And his other interests include being a marathoner and a musician. Thanks, Paul.
Okay, so part two of our discussions today is on knowledge activism, and I've titled it Rising to the Challenge. And knowledge activism is actually, I'll be honest, it's not a term that I heard before I was involved in health and safety. So I will briefly, in my presentation, I'll go over the history of where knowledge activism comes from, and we're going to apply it to where we currently are in the pandemic and where we have been in the pandemic and where we're going. And the idea also is to share a few success stories and where knowledge activism has had some success, especially with around worker representation and advancing rising to the challenge that the pandemic is bringing us, and seeing if we can make meaningful change. Knowledge activism is best understood a worker adaptation structured by the constraints and the opportunities embedded in the current legislative and political economic context. And this is a quote from research done by Alan Hall, Forrest, Sears, and Carlin in their seminal paper, Making a Difference, Knowledge Activism and Worker Representation in Joint OHS Committees. And we'll dig a little bit deeper into Alan's research coming up. But the concept here is that there are constraints placed upon workers and worker representatives based on the current legislation and the forces, the political forces that are imposed on them as well. So some of those constraints, I call them stumbling blocks on worker representatives. Examples here, Walter and Haynes in '88, when they were looking at the internal responsibility system, they found that worker representatives and joint health and safety committees were often ineffective because workers had not been adequately informed about their legal rights, and they linked that to the failure of the Ontario law to ensure worker education. When we speak about worker education, we're really in the sense of training or information and instruction for workers to have, gained the knowledge and to go and apply that knowledge in the workplace. Other stumbling blocks were noted by Story and Luchek in looking at the Bendix asbestos case in Windsor, where they documented the capacity of management to delay action on identified hazards in the face of weak government enforcement. And at the time, the enforcement simply were recommending action rather than giving direction or giving orders. When workers were bringing up the case of asbestos, it was known, the hazards were there, and it was weakened and weakened. They talk about the weakened inspectorate and how that delayed the action of the employer to make meaningful change. Eventually, the closure of the plant with minimal or legal or no statutory sanctions against them demonstrated the power of corporate capital and the conflicting and constrained nature and extent of workers' choices between employment and worker health and safety. And that balance is that, do you want a job or do you want health and safety, which we've heard so much in the past. Glassbeak and Tucker also noted a similar situation in examining the Westway mining disaster, where it was demonstrated that the enormous impact of the labor market pressures and internal management manipulations of those pressures on worker acceptance of hazardous work. And that also is an example of the corporate influences and the pressures placed on workers, where they have to have that balance. Is that, do I want a job or do I want health and safety? The background on Alan Hall's research for knowledge activism was to better understand effective health and safety representation within the current Ontario legal regime of internal responsibility. That's the foundation of the Act, is this internal responsibility system where there's that shared responsibility for health and safety in the workplace. The data collected was through interviews. They conducted interviews with unionized worker health and safety representatives from 27 small to medium workplaces in the auto sector. And out of those interviews, they identified two types of health and safety representatives. There was what they called technical legal representation, and they had politically active representation. Those were the two broad forms of representation they found amongst the worker representatives. These were distinguishable by the former group's reliance on established rules and procedures for identifying and correcting hazards, and the latter group's willingness to challenge the claims and constraints imposed by management. So, politically active, where it's best understood to varying degrees, explicitly or through their behavior, that their capacity to achieve and improve health and safety conditions was a function of the power and their political influence. And in contrast, the representatives talked about their inspections and committee activities in very technical and legalistic terms. So the first group, the politically active, were able to just grasp whatever the health and safety concerns were and push them in a more political and realm through actions and campaigns, and leverage those political influences. Whereas the technical legal representatives were just constrained by whatever the Act says. So we do our inspections once a month. We meet every 3 months, and we do this and we do that because that's what the Act says, and we'll just follow the Act. And because the Act exists, we can ensure a safe work environment. Within the politically active group, Hall discovered a more effective subgroup from the political group, and he called those people political activists. He identified them as also knowledge activists, and this latter group was more effective because they were able to, with political engagement, towards strategic collection, use, and deployment. That was the key aspect, was deployment of that knowledge after gathering it. Characterized knowledge activists by their persistent self-training and sources of information, and their active efforts to legitimate and act on workers' Indigenous knowledge about unsafe or unhealthy conditions. The scale and importance of the issues they addressed, their focus on underlying causes, and their willingness to present managers with solutions. They were also more effective implementers than either of the technical or politically active representatives who did not grasp or mobilize the strategic power of knowledge. When we look at the current COVID-19 pandemic, what can knowledge activists do? What is it going to look like? So it means moving beyond the legal. So whatever the legal requirements on, moving beyond those and the limit data. And as we've learned with COVID-19, the data is always changing, it's always evolving, and we need to be not be limited strictly by what the science is saying. We need to look beyond the science. We look beyond the guidance that is coming out, that is limiting, that is also relying on bad science or as well. And then look at the political forces. And those political forces can be happening internally in the workplace, and the political forces that are happening externally, like in the workplace. So moving beyond all of these constraints. And you can do that by gathering information, you can build relationships, and then make that change. So what is happening then and now? So back in January, February, and March at the onset of the pandemic, we had sick people, we had sick workers, we had novel virus, we had disagreement on the routes of transmission, and we had shifting and confusing list of signs and symptoms, and we had no idea what the long-term impact is. Well, we're now at the end of November. What do we have? We have sick people, we have sick workers, we have a novel virus still that we're still learning about. We have disagreement on the routes of transmission, certainly here in Ontario. We have shifting and confusing list of signs and symptoms. We're learning more and more how they affect different age groups and different populations. And still, we don't know what the unknown long-term impact is. What is the impact on workers? Workers are confused, they're scared, they fear that they're going to contract the illness at work, their fear of contracting the illness in the community or at home, and their fear lies also in infecting someone else or someone close to them. And these are genuine fears. Well, what's driving some of these fears? Well, as John previous presentation on the paper that himself and Peter Smith helped produce, the pandemic survey that OCAO has launched in the early onset of the pandemic, and now is being relaunched. They really noted the perceived inadequacy of PPE among healthcare workers, where in healthcare, only 18% of the of healthcare people that took the survey noted that they had 100% of their PPE needs were met. It's a little bit higher in the non-healthcare settings. And as far as infection control preventions or procedures, similar perceived adequacy of whether their needs were met. In healthcare, only 16.9% of those people that did the survey felt as if their infection control procedures were adequate. And a little bit higher in non-healthcare, but you see the impact of workers' perceived inadequacy of these measures not being in place in the workplace. And what was the outcome of that? It was the high scores of general anxiety disorder, where the less your PPE needs were met, the higher levels of general anxiety. And same thing with infection control. We see that the higher the needs are not met, the higher levels of anxiety that were noted. And the same thing was noted within depression and healthcare workers especially. We look at the provincial pandemic response to also find out what is also driving this fear and this anxiety that workers are suffering. Well, the Ontario Health Plan for Influenza Pandemic was been around for a while, and it was supposed to set out some clear principles. And I'm not sure if all those principles have been met, because some of the principles that were noted was that the future pandemics would be guided by the precautionary principle, and that there'd be health equity, and that vulnerable populations would not be impacted. There were supposed to be adequate provincial stockpiles of PPE. Healthcare settings were supposed to have at least a 4-week supply of PPE, and twice as much in group homes and facilities were supposed to have twice as much stockpiles as well. Look at these, we can certainly see that some of these were not were in place back at the onset of the pandemic, and really contributed to an impact on the workers, which was noted in the survey. And in long-term care, where it was especially noted and especially tragic, it was surprising. I found it surprising because nothing new in long-term care. There have been respiratory outbreaks in long-term care for many years, and that this is not something that is new. But what we observed in the beginnings of the pandemic was that it seemed as if the book was thrown out on outbreaks, because there was a reliance solely on what the Ministry of Health was going to say or how they were going to guide them. And they were also going to lean on the directives from the Chief Medical Officer. But back in early March, we were sounding the bell that you needed to look at your past outbreaks protocols and implement them based on the precautionary principle and based on just general legal requirements under the Act. So those type of protocols include like management of suspected or confirmed cases during an outbreak, not waiting for lab results to take precautions where there is a high risk index of suspicion, the cohorting of staff and residents, masking for both staff and residents, and PPE when performing surveillance. So a lot of these things were not were eventually directed to long-term care homes, but at the onset of the pandemic, they were not directed, or they were not the basis of guidelines. And many homes, in fact, just tossed the book out, as they say, on respiratory outbreaks. Also, what was highlighted as well was canceling of non-essential activities was lead in the pursuit to ensure that the mental health of residents was also safeguarded at the beginning. When we have major outbreaks, many homes had failed to cancel their activities, which led to higher outbreaks and higher number of cases in homes. So the results of some of these missteps at the beginning of the pandemic, mid-June, here are some numbers. 33,853 total cases in Ontario. So out of those 33,000, 5,800 confirmed cases were among healthcare workers, with a breakdown of 81% being female and being male, with nurses comprising the largest proportion of occupations in healthcare at 22%. And outbreak-associated cases were, of the outbreak-associated cases, 69% happened in long-term care. 13 deaths were also reported among healthcare workers. So when we talk about the fear and anxiety, it is justified, and we know where it's coming from. And it's not just within healthcare. We look at the workplaces outside of healthcare that suddenly had to deal with IPAC. Workplaces that never had an IPAC program, like infection prevention and control, never had to deal with it before, never ever really considered it important, were suddenly thrust into that world. And there was some early confusion around whether or not to wear masks and using masks as source control and PPE. And a lot of these workplaces were just not equipped with the tools and resources. They did not perform risk assessments for reopening. And these lack of these tools and resources left not only confusion amongst the workers, but many employers unsure on how to achieve these IPAC measures. We also had working from home. Once the pandemic was declared, well, even when we talk about from early March to the end of March, all of a sudden, thousands and thousands of new workplaces were established overnight in people's homes, with no existing policies or programs, no, as far as ergonomics or violence and harassment for working from home. And there was often an incentive on workers to provide their own equipment and adapt to whatever new technology was required for things like Zoom meetings and having 2 monitors and how to work, how to work more often from a distance. We look at at how we go forward and how we can rely on knowledge activism. We have to start with the Occupational Health and Safety Act. And I can remember when I first started in health and safety, I was often told by many people, underused, piece of legislation, certainly within amongst workers. And I've called it "It's not easy being green." If I may quote Kermit the Frog, he says, "It's not easy being green. It seems you blend in with so many ordinary things, and people tend to pass you over because you're not standing out." And at the beginning of the pandemic and since, I still think we haven't applied the Occupational Health and Safety Act and enforced it to its ultimate benefit and to its ultimate standard as what it is. But we have to ask ourselves, whatever is in the Act, do the minimum standards meet the challenges faced by the pandemic? I've found there are some significant gaps. Joint Health and Safety Committees are required to meet at least every 3 months. Now, if you can imagine, if you're a Joint Health and Safety Committee, if you're in a long-term care home and you met in February and you had to wait 3 months till your next meeting, well, I don't think that is a valuable use of the Joint Health and Safety Committee in the middle of a pandemic with a novel virus. If there was ever a time when committees were needed, now is the time. And even if we can look from May to August, that 3 month span and what that kind of looks like, we can see that Joint Health and Safety Committees have to be on the ball in light of all the emerging science and all the emerging guidelines that are coming out and directives as well. Health and safety representatives for workplaces with more than 6 but less than 20 workers, they do not meet with the employer, and there is no requirement for certification or training for these representatives. Inspections, they tend to focus on the physical condition of the workplace and not necessarily on things that we can't see, like biological and viruses. We can't necessarily see those. Information that's provided to the Joint Health and Safety Committee or Health and Safety representatives are on the hazards and dangers are no basis, which means that if you want to find out about the hazards and the dangers, you have to request them. You have to obtain from the employer information. It's just not it's not guaranteed to be a free-flowing duty of the employer. It's more or less that the request has to be made about certain things, and not only the dangers and hazards in the workplace, but also in similar industries, and find out what are the best practices as well. And occupational health and safety reports are disclosed by consent. If the employer under Section 25 has an occupational health and safety report, copies to the Joint Health and Safety Committee. But often what is point is, well, does this report respect occupational health and safety? And secondly, am I going to disclose it to you? And at the end of the day, it is up to the employer to make that determination as to whether or not this report needs to be disclosed. There's no strict obligation to report to the Joint Health and Safety Committee where a worker has had a high-risk exposure to COVID-19. This has been very limiting when we want to look at contact tracing, that if a worker was exposed, there's not necessarily a strict obligation on employers to provide that information to a Joint Health and Safety Committee or a health and safety representative. And delays in reporting notices of occupational illness for workers that have contracted COVID-19 in the workplace. It is important that that information be shared with the Joint Health and Safety Committee as quickly as possible, so they can help identify what was the sources of the exposure, and they're the best place to identify what those sources are and what were the root causes of that. But when you have a delay of 4 days, that knowledge, that investigation by the committee can be hampered. So when I was speaking earlier about legal constraints. These are legal constraints that knowledge activists have to rise above. But hearing that there is nothing to worry about because they are following public health advice. I've seen in very many emails and correspondences, workplaces and workers, that there is nothing to see here. We are following public health advice. Therefore, everything is okay. But there are flaws within that. Is when they follow public health advice, they are ignoring occupational health and safety requirements. Public health agencies focus on the health of the general public. Public health keeps track of different types of illnesses in the region, and they set expectations and recommended practices for public safety within the framework of acceptable risks. So in health and safety, and when we look at the duty to take every precaution reasonable, the idea of risks and acceptable risks are not contemplated there. Public health agencies have no mandate to protect workers while they are working. It's not part of their act of their mandate, and they are not captured within the Occupational Health and Safety Act or the regulations. Contrary to public health strategies, which are based on acceptable risks, employers have a legal obligation to take all precautions reasonable for the protection of workers. Employers must focus on preventing infection, control, and exposure to the virus. And it's not acceptable for workplace parties to say we are taking our guidance from public health. Remember, we're supposed to be guided by the principle. We've been down this road before with SARS, and as noted by Justice Campbell, worker safety relies on the precautionary principle that reasonable action to reduce risk should not await scientific certainty. And we've seen the debates that have been happening within the realm of science, but have we taken the precautionary principle to heart? So change is needed. Workers need to work. We have a new set of hazards that's been identified. And as the information about transmission risks evolves rapidly, we need to gain that knowledge and gain that information rapidly. And at the end of the day, workers must be safe. So we can redefine this uncertainty, define this this anxiety, this fear that might be out there by looking at OHS and starting from the basics. Although the pandemic has brought unprecedented challenges, occupational health and safety, COVID-19 is a biological hazard, and hazards can be identified, they can be assessed, they can be controlled, and those evaluations can be evaluated over time to determine their effectiveness. And we need to move the discussions beyond personal protective equipment. And we have to ask ourselves, has this been the reality since January, though? Certainly lies within when work tasks are known, when the workplace is known, when the community context is known, and finally, when workers are trained. Now, joint health and safety committees can start. They know the workplace, they know the workplace hazards, and they can work together to find control solutions that work. And like I said, they can ensure that the control solutions continue to work when things change. When new information is presented, it needs to be discussed with the joint health and safety representatives because they are a vehicle for change, and they are the vehicle to communicate that change. So they are the basis of that, but we can move further beyond that. We need to look at identifying and assessing the hazard and the risk. Workplace inspections provide knowledge about workplaces, so that monthly inspection is essential nowadays to look beyond the physical condition, to look beyond what are the protocols that are in place, and to identify if those protocols need to be improved. We also need to relook at our hazard and risk assessments. We need to look at the tools inform the controls required to protect workers. And if they don't exist, new tools can be developed, new hazard assessments can be developed with the Joint Health and Safety Committee. And the hierarchy of control, John mentioned it earlier, that's what's guiding the implementation of those solutions. And in the absence of scientific certainty, we need to err on the side of caution. When we talk about exposure assessments, we need to look at it as a two-way street. We need to look at what is the exposure in the workplace and what is a worker's exposure when they're in the community or when they will confront members of the public, either a client, a student, a customer, a resident, people of those kinds of interactions have to be contemplated in the assessment as well. So we need to look at how much community transmission is going on and whether to decide whether these interactions must occur, and are the workplace preventing the release to the community as well? Are we exposing, is the workplace being a contributor also to community exposures as well? So it goes beyond just simply looking at our workplace. We need to consider where are workers working and what tasks do they perform, and when and where do they interact with others. This is important, and John mentioned earlier about the risk mitigation tool, which can be used to inform those assessments as well. I like to say that this is new hazard, but same controls. We need to look at layering controls using the hierarchy of controls. And we need to move the conversation beyond PPE. I feel we've had too much discussions on while PPE is important, the discussions have had too much of a focus on that PPE, which is the last resort. And we need to move the conversations beyond that to the more effective means of control through elimination, substitution, engineering controls. The paper I'd like to highlight that just came out recently really looked at whether, what was effective training and multifaceted interventions to reduce occupational disease. And their findings was that legislation and regulations can be an effective means of primary prevention, but they're on both the nature of the regulations and the degree of enforcement. They also noted that hierarchy of controls can reduce the risk of some of these diseases and reduce exposures. And monitoring, surveillance, and screening are effective prevention tools, and for evaluating the impact of legislative and policy change. Also noted was the effect of education and training is context dependent and influenced by the manner of delivery. And as I mentioned in the previous slide, multifaceted interventions are often more effective than ones consisting of a single activity. I like to think of it as a basket. You either have, if you have just one reed trying to hold something up, it's not going to be very effective. But if you have interweaving reeds, like woven together in a basket, you're able to hold that worker in a more secure location. Knowledge activists, I highlighted 3 areas in which they can advance their cause in the COVID-19 pandemic. They were gathering information, it was building those relationships, and then taking action. Success beyond committee activities, and the ones we just highlighted previously. It was noted in the research that more time and effort on independent research in order to make the best possible arguments were effective means of amongst knowledge activists. So in terms of COVID-19, we need to do our own independent research on the emerging science on the routes of transmission and the emerging controls that are the most effective. Knowledge activists tend to distribute more of their time outside of the committee context, organizing, educating, and interacting with workers around health and safety issues. And we've seen that happen where we've had unions and other workers educating workers on their rights through online platforms and providing them supplemental information that the employer may not be giving them, such as what is their context out in the community, and what are the best practices in the workplace, and how it affects the worker at the end of the day. Knowledge activists need to build relationships, and we call them allies in the workplace and beyond. So in allies in similar sectors, in other sectors, in the political realm, and with the inspectorate, which is also an important part of it as well. I'll give you an example of some knowledge activism in action. The committee was, a coalition was established, an ad hoc COVID-19 coalition for healthcare. It was, like I said, it was completely put together. It was involved the Ontario Federation of Labour. It involved unions on the Section 21 Healthcare Committee. It also involved unions that were not on the committee, but were also had workers represented. It also had injured worker advocates, occupational hygienists, research and legal advisors, and also had former Ontario public service employees to provide knowledge as well. Some of the resources this committee developed included a COVID-19 health and safety rights guide for healthcare workers. So it was a ground level guide for workers to just emphasize that within the realm of COVID-19, here's a reminder of what your rights are. Very often, I'll give you an example, within healthcare workers is of limited right to refusal. So we really broke down this in the guide, what this limited right to refusal looks like and what the eventually workers' rights are. And we had also discussed areas where there was legal decisions that were made for the betterment of healthcare workers, which I'll be touching on in a few minutes. Also produced was a catalog of COVID-19 resources. The wealth of knowledge that exists out there is a lot. So what was done was we scraped the internet for the best possible resources that exist in different sectors and from different unions, from organizations such as OCAL, from the Workers' Health and Safety Centre, and other health and safety system partners here in Ontario produced a resource guide. I'll provide some of these links after my presentation. The Ad-Hoc committee put on a 2-day event in October with multi-sector union input from ONA, SEIU, Steelworkers, Unifor, CUPE, and OPSU, and we shared success stories. We discussed how has knowledge activism supported change during the current pandemic. Challenges that still exist out there, how can we achieve meaningful change in face of these new challenges? So it was very interactive. We had a lot of good participation, a lot of good discussions that happened. And what was best of all is that it wasn't just limited to healthcare. Other unions were involved and they were able to glean from different sectors what are the best practices for COVID-19. So some of the strategies for change, we have to look to the courts and the Labor Relations Board for some decisions that were made where maybe they didn't take the normal route that we normally take, unions would take when trying to fight for on a particular matter within their workplace. The Ontario Nurses Association, most of you are probably familiar with, in their interlocutory injunction relief, which they sought because they felt that the arbitration system was going to lag, was not going to bring them meaningful change. And they were able to obtain an arbitration award as well following that. SEIU's application under Section 46 led to consent orders, which involved the Ministry of Labor inspecting the workplace weekly for a 2-month period, which is outstanding to hear. But that was based on the health and safety conditions that were there in the first place. Also, there was judicial review of Directive 5 by multiple unions. And in the webinar, we talked about Unifor and USW were collaborating with their employer to develop reopening plans and playbooks on how they were going to put in COVID-19 protocols. And CUPE also was involved to provide sector-specific guidelines and checklists as well. Some resources here, which I'll post up into the chat. as the questions come in. And I'll just this final message from author Stephen Baker is that to bay the cat takes brute force, perseverance, courage of conviction, and a cat. And the last ingredient is usually hardest to come by. So you all have perseverance, brute force, and courage of conviction inside you. And I wish you that you're able to apply those characteristics in your fight towards bettering workplace conditions. So thank you very much.
Thanks a lot, Paul. That was very interesting and a good broad discussion about knowledge activism and how it takes participatory health and safety to another level, but goes beyond that, particularly some of the success stories that have worked for unions and sectors. There are a few questions. I see John's been answering a few of them, but I think you might like to reflect. For instance, there was a question about the difference between knowledge activism and advocacy itself. Do you have any thoughts on that?
It is kind of the same. Like when you're advocating beyond, it's just the thing about knowledge activism is that the key part of this is to gain the knowledge first. You can't advocate on someone's behalf unless you've done that step to gain the knowledge, and also you're better able to advocate upon those people when you're able to build relationships with other partners as well. And that partner can be the employer in certain situations. If you're a worker, if you can gain the ally, your employer as an ally, you're way ahead of the information. You're way ahead of things. But if you're unable to gain them as an ally, there are certainly organizations, other unions, other advocacy groups, which will help in your advocacy. So the term, it kind of describes itself. It's knowledge activism. So it's taking that information and gaining that information, and where you gain that information is very important as well. So I hope that answers the question.
Yeah, I think so. Thanks. And that's actually a lot of the work that OCA has been trying to do and continues to do is translate knowledge for the use of knowledge activists across the province in all the different workplaces and sectors. There were some good comments, I thought, earlier about that it's so important to remember that there's a sector of the working population in settings where there are no joint health and safety committees and where the language of the workplace is not English or French, and I think our regional risk tool also talks about communication is the number one thing. So I guess I don't know if you want to, either one of you or John, you can both, I guess, maybe speak to that. But I think there's a communication of the knowledge, and then what you can do about it, I think, is critical on so many different levels. Well, if you want to add anything to that.
Well, yeah, because depending on the workplace that you're at, you might be separated, and you might not have those close contacts with your workers that you're used to. And this is not a time for people to feel like they're left out on the side, or they're not involved within the health and safety system at your workplace. And I think that some positive things that have come out are these tools, these online tools, which seem to be reaching more people and reaching beyond, things like distance, reaching beyond the workplace and gathering from different perspectives as well. There are certainly challenges to be met, and there are. I would say that there are certain. The COVID-19 has actually shine a light on the areas that we really need to improve, and they brought them to the light. And it's a matter of identifying and getting on top of those challenges, and do your research. And if you don't know where it is, you reach out and get those people involved on the side.
Yeah, if I can add to that, I just posted the 10 operating principles for guiding effective participation from the knowledge activism booklet that's available. And I'm not sure if they all showed up.
I can see them.
Yeah. Well, it looks like the last few did, but I don't see the first few. But anyway, it includes, doing research, doing more than just going to meetings, mobilizing your influence, listening to workers, addressing authority, building trust, being assertive, building solutions, using inspection and minutes strategically, and using the law strategically. So I think that's kind of a snapshot of what knowledge activism is.
I must correct you, John. I only see points 8 to, or maybe a little bit of 7, 7, 8, 9, and 10.
Okay, must have.
Sorry, I had to actually throw my cat outside. He must have, she must have heard your last slide, Paul, which I thought was brilliant. So I had to evict her from the house right now. But I guess what I wanted to say to people is that you can actually unmute yourself to ask a question right now too, carefully in order so we don't have a bunch of echoes. But if anybody has a question or a comment that they would like to add to the conversation, we would welcome that. Vonnie has put the link to our very short evaluation into the chat, and we would appreciate you filling that out so we can have the feedback and so it can inform our future work. And we also put links in earlier about our next event in 2 weeks. But is there anyone that has any questions or comments related to this afternoon's discussion? People who are on the phone can use *6 to unmute their phone if they can't control it on the screen.
Pavel or John, I asked in the chat, Chris Chandler from Ontario Secondary School Teachers Federation. Would you say that with large employers with multiple work sites, that knowledge activism is easier or harder, or has anything to do with multi-site versus site-based JOSHs? Would a site-based JOSH make it easier to activate frontline worker knowledge for the purposes of knowledge activism? I mean, because our employers sometimes have an appetite for site-based because they feel that multi-site has more sort of institutional power and managers can push around workers in site-based JOSHs more effectively. I'm just wondering if you had anything to say about that.
In my experience, the knowledge activists I've known, it's more a kind of personality. They're bulldogs. They grab onto something and they won't let it go. If the environment discourages that, for instance, large institutions often have what I call bureaucratic gridlock. They're so focused on the technical legal approach that they can't see beyond it. It will put up challenges to the knowledge activists. But that's the beauty of a knowledge activist, is they find ways of getting around these barriers and using evidence to prove that there's a problem, and then providing practical solutions that, hopefully the gridlock won't stall. But usually it's these bulldogs that, the personality that grabs onto something and won't let go that gets things done.
Yeah, I know that with when it comes to multi-site, some of the biggest disadvantage from multi-sites is sometimes that there is not a good concept of what is happening on the ground. That is why you might not need to have. If I was a union, and I would not just limit myself to having designated workers do the inspections. I want to inform those designated workers at each location and train them or educate them, because the Act just might say that they just received information on how to do inspections and how to fulfill investigations. I would really reach out to them and say, here's a tool from the Workers' Health and Safety Center It's an inspection checklist for COVID-19. Go through the list, make sure that all your schools have all these things, and look beyond that physical condition. So you really have to build up your little bit of, as John said, bulldogs into a whole army, so that the multi-site committee is better informed from the ground up, instead of just overseeing and hoping and not knowing what's going on individually in those little silos, because that's what they end up becoming. Is I came out of the education sector, and I know about the concept of schools being in silos, and what happens from one is not necessarily shared with the other. I would just like to make another comment. In my discussions, I'm pretty sure I discussed other people that were involved in Allen Hall's research. I might have just, made the impression that it's just Allen Hall who conducted the research. I would also like to highlight the work done at from the University of Windsor. Nikki Carlin, Alan Sears, and Ann Forrest, who were involved in the original research for when they compared the different levels of health and safety representation in the auto sector. I wanted to highlight that before we go.
There is a very specific question here about, should the schools without any HVAC be planning on getting mechanical ventilation, or is that better than open windows and portable HEPA filter units?
How quickly can you install
exactly
an HVAC system? Obviously, it is better to have an HVAC system, and they should be installed. I saw that the province announced another $15,000 for schools ventilation. I'm not sure if it's earmarked for ventilation or what this week. But again, with 5,000 schools, that's about
$3 each.
$3,000. You aren't going to build an HVAC system for $3,000, except maybe in a portable. We're in a pandemic. We weren't planning on this. Well, we should have been planning on this, but we let our plan slip, and so we got caught with our pants down, and now we need to do with whatever we have. So if all you have is open windows and HEPA filters, portable HEPA filters, I would say yes, use them, but also use screening tools. Make sure no one's sick coming into the building. If anybody develops symptoms, look at the risk in your area, cleaning. All those other things. It isn't just ventilation, it's all these things together. It's a puzzle, and if one piece of your puzzle is missing, then you're going to have to rely on the other pieces.
Great, thanks. Anybody else have any questions or comments to make verbally?
Hello, is the PowerPoint's going to be sent out to all the individuals, or are they going to be out on your website?
It will be posted on the website, but we will send an email to all the participants letting you know when the videos and the slides are up. And of course, a reminder about the evaluation. That'll probably be, and a reminder to sign up for our subsequent sessions. That'll all be probably on Tuesday, I would guess, at this point. Okay, thank you. I've already signed up for the next one, by the way. Thank you. That's great. Thanks. Kevin, did you want to say anything about Workplace Health Without Borders, the session that's coming up in December?
Sure. My name is Kevin Hedges. I'm the International President of Workplace Health Without Borders. On the 16th of December, we're running a webinar, an international webinar, and the guest speakers are Professor Raina McIntyre from the University of New South Wales. So Raina's done some fabulous work looking at the efficacy of respirators, N95s compared to surgical masks, which is a real controversial issue at the moment. So I just encourage everyone to chime into that. Were you talking about the one on the 11th too, Val? The care one as well?
I mentioned it in general terms, but you can talk about it if you want in terms of what the content will be. But I just talked about the title, the effective use of PPE as a control.
Yeah, so that one, we're going to be looking at international experience from China and also from Australia. there's also Alec Farquhar is going to introduce a segment from Mario Posamai, who was the chief investigator from SARS-1, and he's also released a new report for the nursing union. And there's a guy called Nicholas Smith from Sudbury. He's been a real advocate for the use of elastomeric respirators, and they should be used. They should be used more widely than they are. So he's going to be promoting that. And I'm also going to be presenting on behalf of a professor from the University of Illinois talking about respiratory protective equipment for non-healthcare. So stay tuned. Thank you.
Yeah, thanks, Kevin. Anybody have any more questions or comments for John or Paul, or just the group in general? Or do John or Paul, do you have any other comments to round out your presentations?
Thank you for joining us. Thank you for listening.
Thank you very much.
Yep, we really appreciate everyone's time this afternoon. And as I said, we will be sending out an email with the links to the slides, to the recordings, to the chat, which has its links in it, and also to the evaluation and to our next sessions. We are also planning one for Friday, January the 15th, that will be talking about the long-term impact of COVID on people's health and how that may, and probably about workers' comp or workplace safety and insurance claims or lack of claims, and then what the long-term COVID means to that. So more to come, basically. Thanks, everybody, for your participation and for your engagement and for your knowledge activism. So everybody has to go to work on Monday and do something related to what you learned today. Thanks a lot. Have a good weekend.